Hi everybody. Just getting ready to start the acid-base balance lecture, continuation of the part 1 lecture that I did Thursday, September 27th. And we started a little bit of this, got through a little bit of it, but I'm going to start at the beginning for anybody who might have missed it. Again, acid-base balance part 2. So we had talked earlier today about possible acid-base disturbances. We noted that there were only two kinds that we can have, either an acidosis or an alkalosis. Acidosis, again, is when there is too much of the hydrogen ion or not enough of the bicarbonate. And alkalosis is when there is too much of the bicarbonate or too little of the hydrogen ion. There can be two different causes. There can be a respiratory cause or metabolic cause. And there can be two different methods of the body for compensating to get that acid base back into balance. There can be a respiratory or a renal compensation. So we have, therefore, respiratory acidosis disturbance, a respiratory alkalosis disturbance, a metabolic acidosis disturbance, and a respiratory alkalosis disturbance. Going to just kind of go through each of those. Again, remembering, as shown on this slide, that alkalosis is when the pH level is over literally a 7.4. However, in the body, it has to be higher than 7.45 to constitute an alkalosis. For an acidosis, the pH should be below 7.4, but again, in the body, we are considering an acidosis condition to be below that golden number of 7.35, okay? I talked briefly in class about looking at the various measurements that we use when we're doing blood gases, and they are able, if we start thinking of them in connection with whether or not the hydrogen ion is elevated, whether or not the carbon dioxide level is elevated, or whether or not the bicarbonate element is elevated, it starts to become easier to see when we look at those values in our blood work what exactly is going on with the patient. So in this particular chart, there are arrows drawn, and for myself, I find it easily when I correlate the arrows to the various values. So in a metabolic acidosis, again, an acid condition will have a low pH, and of course, since there's an inverse relationship with the hydrogen ion, an acidosis will have a high hydrogen ion content. Now, in this particular disorder, metabolic acidosis, there's a shortage of the bicarb shown in blue. So the pH and the bicarbonate arrows are going in the same direction, which is another way to key into whether or not it is a metabolic condition. And you can also see that there could be a lower carbon dioxide, but in the primary disturbance, which is what we're looking at, we're going to note that a metabolic acidosis will have as hallmarks a low pH and a low bicarbonate HCO3. The opposite of that, a metabolic alkalosis, now the pH is elevated and the hydrogen ion is down, again that inverse relationship, with a bicarbonate elevated, okay? Secondary response, again, we might have the carbon dioxide, the PCO2, elevated, but again, the main issue here is the bicarbonate disorder or related disorder, and so we see the arrows for the metabolic condition, the arrows of the bicarbonate, and the pH going in the same direction. Conversely, when it's a respiratory condition, you're going to see that the arrows of the pH and the PCO2 go in opposite directions. So there we have the acidosis, pH is low, hydrogen high, PCO2 high, and the bicarb is also high, just incidentally. We happen to have in the respiratory alkalosis a high pH, a low acid, a low hydrogen ion, and a low PCO2. So again, arrows going in the opposite direction. And we also see the bicarbonate is going down too in this particular condition. Okay, so the green arrows, the green area of the chart, the secondary response is actually the body's effort to do something about these disorders. So for the moment, don't pay much attention to that until we discuss that later and how the body is compensating. Just for this part of the lecture, pay attention to the red arrows and the blue items, okay? Again, remembering that when a condition is metabolic, it's either metabolic or it's respiratory. When it's metabolic, the arrows of the bicarbonate or the levels of the bicarbonate and the level of the pH will go in the same direction. And when it is respiratory, the levels of the pH and the levels of the PCO2 will go in opposite direction. That is the main takeaway from this slide. Let's talk a little bit more about acid-base balance upsets. Again, we said there can be a couple causes, and one of them is when there are too many hydrogen ions. It's a condition, it's not a disease, but it can be caused by a disorder or some kind of a pathological process or some kind of a disease. It can be from metabolic issues, or it can be respiratory problems, or sometimes, like in a code situation, a code blue where someone is not breathing, we might have both metabolic and respiratory problems causing this acidotic situation. In general, patients that are at greatest risk are those with impaired breathing problems, okay? Those that are unable to do something about that hydrogen ion quickly. And the quickest way to do something about a hydrogen ion is to blow off the carbon dioxide, as we talked in the earlier lecture, so that the hydrogen ion also is taken away with it, okay? I have also noted here on this slide that you can look at those older adults that have chronic health problems and why exactly they are at risk, at greatest risk, to be having an acidotic condition. If you look at your IGI book, the Ignatius book, page 179, chart 12.2, that will show you, actually, I'm sorry, it's page 191, chart 12.2. This, I must not have updated this slide, I apologize. It's actually on page 191, chart 12.2, about older adults that have chronic health problems and how they are at greater risk for acidosis. Causes of acidosis. In general, there's two causes. They can be respiratory, which we see on the upper right hand side of this page to the upper right of that black line there, and then the metabolic issues, which are on the lower left part of the black line there, the black line that draws is splitting the screen in half. So if it's a respiratory cause of acidosis, it could be related to something that keeps the person from breathing adequately, or what is also called hypoventilation. So there might be an airway obstruction. The person may have choked on something, or they have a pulmonary emboli, or something is obstructing their airways and they're not getting a good exchange. So the carbon dioxide is building up. There may be chest trauma, there might be a neuromuscular disease, something is happening and that person is not able to do a good chest expansion when they're breathing, so they're not able to put in a good deep breath, okay? Pulmonary edema might also cause a problem with the chest expansion. Drug overdoses, there are drugs that will tend to turn off the body's chemoreceptors that are interpreting the carbon dioxide level in the body, and so that would slow the person's ability to breathe at all, sometimes even completely shutting off your body's tendency to draw a breath. Metabolically, anything that will cause a problem with the acid condition of the body. So, for example, diabetic ketoacidosis, where the lack of ability to break down glucose correctly leads the body to break down substances into lactic acid, and that leads to this acid condition. Severe diarrhea, shock, can also flush some of the bicarbonate out of your system, and so the body has no ability to counteract the acid that it forms routinely in its metabolic efforts, because the bicarbonate has been flushed out of the system through severe diarrhea or renal failure, where the kidneys are not reabsorbing the bicarbonate into the system. And salicylate or aspirin overdose tends to form acid in the system, and you become very acidotic. Sepsis and shock also will tend to form acids or cause a formation of acid in the body because the oxygen levels are low in people with sepsis and shock, and so they are not able to use aerobic metabolism to break down their food, and they become very similar to the diabetic ketoacidosis, where lactic acid is produced in abundance, creating an acid condition in the body. Okay. When you've got an acidosis, the main problems result from this imbalance, or the excess of positively charged ions, hydrogen ions in particular. This can also lead to other ion imbalances. Potassium, as we heard with our lectures a couple weeks ago, potassium tends to leave the cell where it's been hanging out and try to counteract that excess of hydrogen in the body, because when potassium comes out of the cell, the hydrogen is pulled in. However, now we've got other issues going on with the potassium coming out. We might have conduction issues or issues with nerve, cardiac, and skeletal systems, and then we can see some manifestations in those systems, all again due to the fact that we had an acid condition or an excess of hydrogen ions in the body. Again, in your IGGI book, the Ig Nativicius book, there is a chart, not on page 180. It is page 191 and 192, a table there that has causes of acidotic conditions listed. And if you read the 2 pages there, there's great explanations of the different causes and how that leads to an acidosis. Sorry, I'm at home. That was my cuckoo clock. All right, symptoms are outlined pretty well on this particular slide here. You're going to see a headache, sleepiness, confusion, and as the acidotic condition gets worse, there might be loss of consciousness and coma. Respiratory, you're going to be short of breath, might have some coughing. Again, the lungs read this excess hydrogen ion and may start trying to breathe more rapidly to blow off the carbon dioxide and remove the excess hydrogen ion from the system too. The heart you will have arrhythmias, increased heart rate, nausea, vomiting, and diarrhea. The whole GI tract tends to speed up. Ultimately, you're going to have seizures and weakness as that acid condition takes over. Okay, talking a little bit now about alkalosis, kind of the other end of the spectrum, happens from excess of bases in the system, and 9 times out of 10 it's going to be the bicarbonate. And at least in this class, we're going to focus mostly on bicarbonate issues, alkalosis caused by bicarbonate issues. Again, remember, alkalosis is not a disease in itself, but it is caused by some other disorder or pathological process that's going on. It can be metabolic or respiratory, or again, it can also be both, as we'll see when we get into a little more detail with each of the systems that are affected. Causes of alkalosis, and now we'll look at the upper left, I don't know my left and right very well, the upper left side of the screen above the black line, and one cause of alkalosis can be related to the respiratory system. In this case, any condition that would cause you to hyperventilate or cause the patient to hyperventilate. So we're blowing off the carbon dioxide, taking the hydrogen ion with it, so to speak, and now we've caused the pH to go up as the hydrogen ion on the CO2 go down. Again, you are hyperventilating in this particular instance. It can be caused by anxiety. It can be caused by pregnancy. Sometimes the sense of fullness that you feel when you're pregnant might cause you to hyperventilate a little bit, or that pressure to breathe with baby in the uterus there. Can be caused in fever as your temperature elevates. It's kind of like extreme exercising. You feel the need to hyperventilate a little bit initially when you've got a fever. And you can get it in the beginning stages of pulmonary emboli, like this feeling of dread, something's going to happen, and so you hyperventilate. Also at high altitudes, probably due to the low oxygen, you will hyperventilate, and that could cause a respiratory alkalosis. On the other side of the arrow, going at the right lower area, below the black area on the screen, or the black arrow on the screen, there are metabolic causes, okay? Well, one of the top ones is somehow you're losing those gastric juices. Either there's an NG tube attached and we're suctioning them out. We do sometimes put the tube in there and keep using it for people with pancreatitis, things like that. Or there might have been an excess of potassium wasting diuretics. Remember, the potassium also tends to pull the hydrogen with it, all right? So when the potassium goes, the hydrogen level may also go down. Just kind of an interesting complication of those potassium wasting diuretics. And also if we've got antacid abuse of antacids, because they have bicarbonate and other kinds of alkalotic materials in them, and so we might take in too much alkalotic substances, and that will cause a metabolic alkalosis. So let's get into a little more detail now with respiratory acidosis. Remember, respiratory acidosis occurs basically by the failure of the respiratory system to function correctly. It is actually the most common type of acid-base imbalance, the one you're most likely to see in the hospital or wherever you might be analyzing arterial blood gases. Basically, there's a buildup of carbon dioxide in the blood. And unlike metabolic acidosis, there's really only one cause of respiratory acidosis, and that is building up or retaining the carbon dioxide. Because the carbon dioxide is increasing, we have a decreasing pH. So the decreasing pH, or the acidic condition, And the increasing PCO2 are the characteristics of respiratory acidosis. Again, kind of as a review, that PCO2 notation that you see on the page here means the partial pressure of carbon dioxide in the blood, in case you didn't recall that from earlier classes. Exact causes of respiratory acidosis, you can kind of think through anytime a person has inadequate ventilation or inadequate ability to expand the lungs well enough to get oxygen where it needs to go. So this can also involve infections like pneumonia, where the alveoli is blocked off from the buildup of some type of a bacterial substance, mucus in the lungs. Also get it with cystic fibrosis, same thing as pneumonia, although not caused by bacteria, but now the person's own lungs are actually building up mucus within them, and they can't quite get adequate ventilation. With emphysema, there is kind of a thickening of the walls of the lungs and kind of a resistance to getting the lungs full enough, and then actually again emptying them. So there's kind of resistance to the inhalation and exhalation so that the person cannot adequately pull in oxygen and blow off carbon dioxide. You can also have respiratory acidosis when a person suffers from inadequate chest expansion, maybe broken ribs in a car accident, or maybe some type of injury that makes it painful for them to breathe, and so they won't take a big, deep breath like they need to. You can get it with respiratory depression. Probably the most common respiratory depression that we see is someone who's had anesthesia, where basically we turn off that person's desire to breathe with our anesthetic drugs. Interestingly, you can get this too with opioids. Too many opioids will shut down your respiratory center's command to breathe, because the opioids tend to block, again as I said earlier, the chemoreceptors that are interpreting the amount of carbon dioxide in the blood. And finally, you can see respiratory acidosis when someone has airway obstruction of some kind, where pulmonary emboli or maybe food caught in their throat. I said the hot dog, choking on a hot dog. That's usually a really good one too. But anything that will block that airway and cause a person to be unable to breathe. Patients that are at greatest risk are those, of course, with impaired breathing. We talk through these classes, but again, the four main ones that you'll see in that table, again on page 191 in the Iggy book, has these four main classes. Depression, respiratory depression, inadequate chest expansion, airway obstruction, or for some reason there isn't adequate capillary or alveolar diffusion into the lung areas. Here's a picture kind of showing the various signs and symptoms that you might see, as well as some causes in the lower right-hand side. First of all, the person won't be breathing very well. They'll be hypoventilating. They'll report not being able to catch their breath, assuming they're not choking on something and can actually talk. They will have rapid, shallow respirations, but they're not very effective, okay? The blood pressure will go down as the body vasodilates in an attempt to find some oxygen somewhere. They could have dyspnea. Because of the low oxygen, they're going to have a headache, and they may have hyperkalemia, high potassium, as that hydrogen builds up, the potassium builds up also. Might have dysrhythmias because of that high potassium. They can get drowsiness, dizziness, disorientation, muscle weakness with a bit of what seems counterintuitive, a little bit of hyperreflexia too. And again, there's the causes listed down below. Respiratory acidosis can be acute or chronic. And if the acute imbalance is usually pretty dangerous because there's an acute onset to it and the body needs to react quickly. But again, it's a respiratory issue, and so sometimes the body's mechanisms of repairing itself quickly aren't available. Okay, so remember we said that when they're the phases of body compensation. The first phase is the buffers. The second phase is respiratory accommodations, and the third is renal or kidney accommodations. When the respiratory system is involved, it cannot always compensate to make things better. Okay, so when it is an acute situation, your bicarb level usually remains in the normal range because, again, the renal compensation is slow, the third phase, renal. When it's chronic, like in COPD, the kidneys are compensating, and the body tends to get used to that higher PaCO2 level by increasing the carbon dioxide, but also the body will tend to, as I talked about in class, start interpreting the oxygen level for its mechanism to breathe instead of the carbon dioxide level. Respiratory acidosis is always due to inadequate or inability to get rid of that carbon dioxide. So there's an increase in carbon dioxide, which results in an increase in hydrogen ion. And remember, when the hydrogen ion goes up and the CO2 goes up, the pH goes down, an acid condition. In addition to the elevated partial pressure of CO2, the PaCO2 means the partial pressure in the arteries, okay? It might be PvCO2 for venous, or it might be an SA, which would be a saturation level. We'll talk a little bit about that later. Anyway, in addition to the elevated PaCO2, hypoventilation will also cause a decrease in the partial pressure of the arterial level of your oxygen. So you're going to see a decrease in your oxygen level. Again, you'll see this with pulmonary edema, aspiration, atelectasis, pneumothorax, overuse of sedatives, and of course pneumonia. Chronic respiratory is usually associated with those problems that people have for a while, like COPD or emphysema, things where the respiratory system itself isn't as flexible as it used to be, like with asthmatics, where they might have some swelling in their bronchial areas and then they cannot really breathe in and out as easily. Again, on page 191 in your IGGI book, there are other causes listed there. Just remember, when that PaCO2 is suddenly elevated, you're going to have the body's response, an increased heart rate, an increased respiratory rate, and an initial increase of blood pressure as a response. But you're going to have mental cloudiness or confusion by the patient, and suddenly a feeling of fullness in their head. Something isn't quite right as the body struggles to get that oxygen where it needs to be. Okay, the increase in the CO2 level causes cerebral vascular vasodilation, and the body sends more blood flow there so that there's no damage to the brain tissues. And this happens in particular when there's more than 60 millimeters of mercury increase of the PaCO2 level. What do we do to treat it? Obviously, if we can make the person breathe better or improve the ventilation, we can treat it very effectively, but it's going to depend on what is wrong. So the exact measures vary with the cause. If it's something like the asthmatic attack, we might use bronchodilators to reduce that bronchial spasms. Antibiotics, ATBs, they're used for infections, clear up the pneumonia. Sometimes we do what's called a pulmonary hygiene or a pulmonary toilet, measured to rid the respiratory tract of mucus and drainage. I know when my son was in the hospital with pneumonia, they flipped his bed so that he was in a Trendelenburg and would kind of pound on the back of his chest with the cupping. The respiratory therapist did that with a cupping type motion on the back of his chest so that he would cough up the excess mucus and drainage. We might do those kinds of things, and that specific action is called pulmonary hygiene or pulmonary toilet. We will also try to force fluids to keep those mucous membranes moist, and also the forcing of fluids help the person to cough anything up like a phlegm or something with pneumonia that might help to clear those lungs a little bit better. We give supplemental oxygen if needed or as needed. And then if we are not having much success with what we're doing to get the person to breathe better, they might need to be mechanically ventilated. Okay. And here's respiratory acidosis, kind of a breakdown of it, things to remember that cause it, and things that might like symptoms that the person might have from it, okay, both chronic and acute. Okay. Moving on to respiratory alkalosis. This is where the carbon dioxide is removed quicker than what it should be, or quicker than we produce it. The most common cause of respiratory alkalosis is hyperventilation, hardly ever associated with a disease, but again, it can occur when a person's having anxiety, fever, sepsis, or strenuous exercise. You tend to breathe much more quickly than you would normally, and you blow off that extra carbon dioxide. So the hallmark in our blood gases of respiratory alkalosis is the elevated pH level coupled with the low CO2 level. All right, remember the arrows going in the opposite direction. pH up, carbon dioxide down indicates a respiratory condition, and in this particular instance, it will be a respiratory alkalosis. In general, when it's acute, the oxygen and the bicarb are normal level. Respiratory alkalosis is always due to hyperventilation, blowing off that extra CO2 and decreasing that weak acid, the carbonic acid, H2CO3. So it will decrease that because we've removed the CO2, and so there is no carbonic acid formed when the CO2 is lacking. Causes, again, anxiety, high fever, low oxygen, sometimes in early salicylate intoxication, gram-negative bacteremia, lesions of the central nervous system that are causing problems with the respiratory center, pulmonary emboli initially, just like with early aspirin or salicylate intoxication, initially the person will hyperventilate. And then there's also kind of an interesting one that you might see in the intensive care unit when there is excessive ventilation by the mechanical ventilator. In other words, the ventilator settings are too high and the person is breathing too rapidly and blowing off too much carbon dioxide. Here are some causes, some of the symptoms, and basic things that would get you in this kind of trouble, okay? This shows a little bit of the symptoms again and the progression. As the symptoms get worse, of course, you blow off too much PCO2, you're going to get lethargy, confusion, lightheadedness. Eventually, you're going to have a very low blood pressure with a tachycardia and seizures possibly when it's gone on too long. Okay? The treatment, Usually what we end up doing, especially if it's like an anxious person or someone that we can actually communicate well with, we might give them a paper bag to breathe into or tell them to breathe more slowly so that they calm down and they're actually rebreathing the carbon dioxide that they were blowing off, okay? Usually, if this does not work, and breathing into a bag or breathing more slowly is not working or they can't cooperate, we might give them a little bit of a sedative to kind of slow their breathing down. And other things, other causes, again, are directed at correcting the underlying problem. Okay, so if it's fever, we might give them something to correct that fever or lower the fever. Moving on to metabolic acidosis now. This is a disturbance not caused by too much or too little carbon dioxide. Now we're going to focus with these metabolic disturbances on the bicarbonate level in the blood. In general, bicarbonate in the blood is above or below the normal range of 22 to 26. So we'll start memorizing that now. The bicarbonate normal is 22 to 26 milliequivalents per liter. And when it's too high or too low from that normal range, we start to see issues, okay? Metabolic acidosis, by the way, is the second most common acid-base imbalance. And in this particular case, the hallmark of this, the blood pH is low and the bicarbonate level is low. So thinking of the arrows again, you're going to see the pH level and the bicarbonate level going in the same direction. They're going to be lower than normal, both of them. You can get metabolic acidosis from too much alcohol ingestion because as we drink a lot of alcohol, we form acetic acid. The body tends to break alcohol down into acetic acid. We can also get metabolic acidosis from a large loss of bicarbonate, which would be someone with persistent diarrhea for whatever reason. And again, I talked about diabetic ketoacidosis. That's probably one of the most frequent causes that we see. The person is not breaking the glucose down correctly and building up excess lactic acid, which puts the person into a ketoacidotic state. So here's just some like a cartoon memory aid to this, showing again the low pH because of the loss of the guy in the blue suit losing the bicarb for some reason, and there's too much acid accumulating when the bicarbonate is not around to kind of pull that hydrogen ion out. Possible causes: ketoacidosis, shock, severe diarrhea. Wow. Interesting picture. Impaired kidney function. So for some reason, the kidneys may not be reabsorbing the bicarbonate or perhaps not able to make it as it does when the urine is formed. Sometimes the bicarb can be made from some of the products in the urine and then put back into the system. In the warning signs and symptoms, headache, lethargy, anorexia, kind of sounds a lot like some of the ones with the respiratory acidosis. If you've got a metabolic acidosis that's caused by diabetes and a buildup of the keto acids or lactic acid in your system, your respiratory system will try to blow that off, and you will see the deep, rapid respirations called the Kussmaul respirations. Those are real particular to a diabetic ketoacidosis. Might have nausea, diarrhea, abdominal discomfort, and as it progresses, the person can get into coma and dangerous dysrhythmias. Okay? 4 processes that lead to metabolic acidosis. We're either making too much hydrogen ion, we aren't getting rid of it, or we're under eliminating the hydrogen ion, or with the bicarbonate. We're not making enough bicarbonate, or for some reason we're getting rid of it too much or too frequently. And again, the table 12.2 on page 191 has a lot of those causes as well as explanations that are helpful in understanding how metabolic acidosis can occur. Lactic acidosis is also a cause of metabolic acidosis. I said we can see it sometimes in the diabetic patient, but you can also see a buildup of lactic acid in patients that have significant cardiopulmonary problems and those with sepsis. One of the hallmarks of sepsis, we'll find out when we talk about that in a couple weeks, is the lactic acid level. We actually try to determine if a person's becoming septic or not by looking at their lactic acid level. Anyway, when we don't have enough intracellular oxygen, we tend to produce energy by the anaerobic metabolic pathways. Remember, we talked about that a couple weeks earlier. When we do that, when we break the glucose down, and we aren't able to do that in the presence of oxygen, then we will produce a lot of lactate and a lot of hydrogen ion, which in turn form lactic acid in the bloodstream. And that accumulation of lactic acid produces a decrease in the pH and a metabolic acidosis condition. Elevated lactate levels are strongly correlated with mortality in critically ill patients. And so we try to keep a close watch on lactate when we think there's an acidosis going on. If that lactate level gets up around 10, the mortality or the death rate is about 95%. Most people don't survive a lactate over 10. The norm of lactate is less than or equal to 2.5. Okay. When a person is on stress, nothing going on, kind of a normal, the level would be 0.5 to 1. Critically ill patients can be considered to have normal lactate a little more elevated than the 0.5 to 1, all the way up to 2. But once that lactate is greater than 2, we start to get a little bit worried about it, and when it gets up over 4 to 5, then you start to see the metabolic acidosis going on. Ketoacidosis, again, that we see with diabetics with high levels of glucose in the bloodstream. Again, there is a lack of ability to break the glucose down, usually because the person has a lack of insulin. And again, when the insulin is not able to bring the glucose into the cell so that it can be used, the cell will use something else for energy, and the byproduct of that is generally lactic acid also, and ketones, and that will make a metabolic acidotic condition too. So you see in the picture there, usually the insulin is the key, kind of almost shaped like a key in that picture, that allows glucose to get into the cell and be used for energy. But when that doesn't happen, the cell uses anything and everything that it can and produces lactic acid as well as ketones that are not very good, or that cause this acidotic state. If a diabetic patient has severe insulin deficiency, there will also be other kinds of things that will go on. Of course, lipolysis, or the breakdown of fats, will also occur. That releases free fatty acids into the liver, and that again is very acidotic. They are converted to ketones. Ketones are kind of an acid type substance, but what they end up doing is kind of decreasing the bicarb. So you can kind of look at this picture here and read through it to see exactly what's going on with diabetic ketoacidosis. Sorry, my cuckoo clock again. But overall, the net effect is that the person will get into an acidotic state, and it's metabolic acidosis. Again, as I said earlier, we can also have an alcoholic ketoacidosis. Usually the person that gets into this state have been on a recent drinking binge and they aren't really eating well, so they can get a ketoacidosis also. Their body will use other things, break it down, as well as converting the alcohol into acidic substances, and they can also have really decreased pH levels. Starvation is another condition that can cause metabolic acidosis because, again, if you're not eating things correctly, the body will break things down to get the energy it needs, and we can get into a similar situation with keto acid production or lactic acid production, fatty acid production, those kinds of things, all leading to a metabolic acidosis. Toxic substances that themselves form acids when taken into the body, like salicylates, which are aspirins, methanol, ethylene glycol, all of those can break down into what are called metabolites, or the pieces of those substances, and those actually cause an acidotic condition. Renal failure is another thing that will happen because then we have a buildup of urea when it's not taken out of the system with the kidneys functioning well, and that will cause a uremic acidosis, ultimately leading to a metabolic acidosis. Diarrhea causes a loss of bicarbonate in the stool, and when that happens, there's not enough bicarb to actually deal with the normal hydrogen ion levels that we would see, and so you can get a metabolic acidosis. And then you can have other causes if we happen to be giving different medications that could increase chloride. Excessive chloride will cause what is known as a hyperchloremic acidosis. Okay, those are kind of rare. I don't usually focus on those too much. Can't even think if I've ever seen somebody in that state. But yet another cause of acidosis could be problems with the chloride. How do we treat metabolic acidosis? Again, it varies according to the cause. If you've got renal failure, you have to do dialysis. In ketoacidosis, we would give insulin and fluid replacement to correct the low pH values and kind of flush some of those unneeded substances out of your system. You tend to get dehydrated in ketoacidosis, but that's another story when we go over diabetes. But again, the treatment is very focused at what the cause. We don't necessarily give alkali therapy, but we could if somebody is severely acidotic. And what we do then is just inject alkalotic agents to kind of bind with the acid. Bicarb is the number one. You see that sometimes in codes where the person has been not breathing for a while and they're getting more acidotic. Sometimes we will inject the bicarb to reverse that. We can also give tromethamine, and some salts of organic acids can be given too. But again, that really depends on the severity. It has to be pretty bad before we will actually give somebody an alkalotic agent. If we do, again, it's most frequently the sodium bicarb because it works right away, doesn't need to be activated, and we see pretty quick results, right? But we've got to be careful about giving too much bicarb because that has issues of its own. It can also result in cardiac arrhythmias and tetany. So you may not see a bicarb given right away to reverse a metabolic acidosis. Here's a little memory aid showing again the signs and symptoms. Warm flushed skin is very, very common. Usually, particularly in diabetics, they will seem like they have been sunburned because they get the very lot of systemic vasodilation, and so they will seem almost reddened in appearance. GI upset is pretty common. And there are also some changes in level of consciousness that occur too. Again, the Kussmaul respirations, and then the causes listed there. Metabolic alkalosis, the final one we're going to talk about, that now is going to have a rising blood pH and a rising bicarb level. It's much less common than metabolic acidosis, and usually what has happened is we've lost the acid somehow, or for some other reason we are retaining the bicarbonate retention. So the most common cause of metabolic alkalosis is vomiting or perhaps gastric suction. We've had the suction going on too long and we haven't been careful about replacing what we've been taking out of the stomach. Constipation sometimes can lead to a metabolic alkalosis because then there's too much absorption of the bicarbonate in the colon area. Sometimes, and actually I guess I shouldn't say sometimes, pretty frequently, you can see a metabolic alkalosis with someone who takes a lot of antacids, so an excessive intake of bicarbonate. Citrates, bicarbonate antacids. You will also see it if there's a lot, like extreme loss of potassium with diuretics, because it tends to take the hydrogen ion along with it when it leaves. And then you will see it sometimes in some diseases like hyperaldosteronism and Cushing's disease. Remember, hyperaldosteronism, an overactive aldosteronic adrenal gland might produce that aldosterone in large amounts, which will deplete the potassium in someone's system. Here's just a memory aid here with the metabolic acidosis and the different things that could cause it on the left-hand side, as well as some of the things that we might do to the warning signs and symptoms in the lower side there. Sometimes, I was looking at the TPN infusion, sometimes we aren't careful what we put in the total parenteral nutrition infusions, and if we don't have enough of the vitamins and things in there that are needed, or potassium, we might inadvertently cause an excess of the bicarbonate. Okay? So metabolic alkalosis, the hallmark of metabolic alkalosis is an elevated pH coupled with an elevated bicarb. Remember, the arrows going in the same direction means that it's a metabolic condition. Again, usually the oxygen and carbon dioxide are normal. Primarily, symptoms that are related to decreased calcium ionization. When the bicarb is a higher level, calcium is affected. So you're going to see the symptoms of low or hypocalcemia too. The tingling fingers, toes, dizziness, and the kind of hypertonic or hyperreflexive muscles. Respirations usually are depressed because the lungs will try to hold in that carbon dioxide so that the hydrogen ion will also stay. So, other things that we look at with a metabolic alkalosis, we check those lab values carefully, particularly potassium, chloride, and calcium. Okay. Sometimes when there is low levels of hydrogen ion, you might see the potassium drop, so we keep an eye on that. In general, the chloride level might be lower because of that elevation in the bicarb, tends to pull the sodium with the bicarbonate, and that makes that chloride ion kind of get flushed through the system. So we keep an eye on that. Calcium also is decreased in alkalosis as the calcium tends to, the free calcium in the blood tends to combine with serum protein. So we watch for those symptoms of hypocalcemia in a metabolic alkalosis. Sometimes they are the main symptoms that are seen. Can be acute or chronic. Again, we treat it by trying to understand what was happening and reverse it. Might include restoration of normal fluid volume by giving sodium chloride because that volume depletion tends to maintain that alkalosis. And we've got to make sure we keep those chloride levels up because with the chloride levels combining with the bicarb, it will help to excrete that excess bicarb. So give sodium chloride for that to help the kidney out in getting rid of the excess bicarb. Again, here's memory aids showing the actual symptoms and causes of metabolic alkalosis. I want to talk a little bit about some of the mixed acid-base imbalances. In some situations, patients might have 2 or more of these going on at the same time. First of all, the one I talked about quite a bit, cardiopulmonary arrest, the patient will have a metabolic acidosis and a respiratory acidosis going on at the same time. Because they're not breathing, they are going to retain carbon dioxide, and then because, again, of the lack of oxygen, there's going to be a lot of lactic acidosis. And that is not counteracted. It's overwhelming for the bicarb. You can also get a metabolic acidosis and a respiratory alkalosis when you have salicylate or aspirin intoxication, just because the salicylate tends to alter metabolism and causes an overproduction of certain acids, which decrease that bicarb, take it kind of out of commission, and it also increases the respirations because it stimulates, the salicylate stimulates the respiratory center. So you're going to have those two combos going on with salicylate intoxication, aspirin overdose. You're going to have you could have a metabolic acidosis and a metabolic alkalosis going on at the same time when you've got renal failure with vomiting. Renal failure will cause retention of acids, and there will be a decrease in the bicarb, while the vomiting will cause a loss of acid and an increase in the bicarb. So interestingly, you can have those two going on at the same time if you've got a renal failure patient vomiting. You could have metabolic and respiratory alkalosis going on at the same time when there's vomiting during pregnancy or hyperemesis gravidarum. The vomiting will cause the loss of hydrogen and increase the bicarb, and yet the progesterone will increase during pregnancy, and that will stimulate the respirations and a decrease in carbon dioxide. So you can have those kind of interesting combinations of acid-base disorders. Vomiting with COPD also causes metabolic alkalosis and respiratory acidosis for the reasons that are listed there. And ultimately, some other things we want to recall, I think I've said this multiple times, but just to be sure, pH does affect the potassium balance. We talked about this in our potassium lecture, but generally acidemia, a decrease in the pH, will cause an increase in the potassium ion. Again, a decreased pH leads to an increase in hydrogen ion and also an increase in potassium, moves out of the cells. The opposite will happen also. An increase in the pH will decrease the hydrogen ion and move potassium back into the cells, lower the potassium concentration. So we would get hyperkalemia in an imbalance of increased hydrogen ions, which is acidosis, and you get a hypokalemia with an increase in the pH or a decrease in the hydrogen ions, which is an alkalotic condition. There's compensation that's going to happen also, and it will be either respiratory or renal, okay? In general, if the respiratory or renal systems are not the cause of the imbalance, they may compensate. So, respiratory compensation is accomplished by the alteration of the rate and depth of the ventilation, and that is immediate. Renal compensation, on the other hand, will involve some changing of the method of the kidneys working in general to either retain or eliminate bicarb, and that can take much longer to be effective. Okay, so we're going to just do some quick analysis of ABGs levels, and we're just going to use a very general approach initially before we get more detailed to more complicated cases. Remember, we talked about the normal ranges, the pH 7.35 to 7.45. PCO2 tends to be 36 to 44, okay? And the HCO3, the bicarb, tends to be 22 to 26, okay? Just to get a good idea of how to do this, we're going to use the middle point of the ranges. So we're going to say the norm, just so we can kind of get an idea here, is going to be pH 7.4, CO2 40, and HCO3 24. Just as we first start looking at these, we'll go back to the ranges when we get a little better at this. So using those norms, we're going to first go and figure out the acid-base status. Then we're going to look at the system that might have the primary disturbance, and then we're going to try and see if compensation is happening in the other system. All right? So our methodology, we will determine the pH, and if it's high, it's alkalotic. If it's low, it's acidic. Okay? And that will tell us whether it's an acidosis or an alkalosis. Then we'll look to see whether the respiratory parameter, the PCO2, we always go to that next, is that high or low? And if it is high or low, is that account for what we're seeing in the pH, okay? And then our next step would be, is the metabolic parameter high or low? And if it is high or low, might that account for the pH or the acid-base disturbance? So that way we determine which system, respiratory or metabolic, is the one involved in the acidosis or alkalosis condition. Just going to use very simple acid-base disturbances. So only one system will have the primary disturbance, keeping in mind, based on the patient history, that it can be more than one system, just like we saw previously. But for our sake of understanding here, we're just going to assume it's only one. Once we've determined the system that seems to be causing the problem, we're going to see if the other system has tried to compensate or not. And so what we will look at is to see if the system that is not involved is changing in a way that will work against what is going on. So if it's an acidosis condition, we'll see if the other system is working toward making things alkalotic. Okay, again, remembering the compensating system is either respiratory or renal. Other systems can cause problems, okay, but only the renal system can compensate for respiratory disturbances. Just keep those things in mind. Here's our simple example. Got a pH 7.25 from the arterial blood gas. PCO2 is 70, HCO3 is 30. So first we look at the acid-base status, and we're going to use our norm of 7.4. This person is below 7.4, so it's acidosis. We haven't determined yet if it's metabolic or respiratory, but we are here on this next slide going to do it. So now we look at the respiratory parameter, the PCO2. Can that explain or account for the acidosis going on? Since the PCO2 is 70 and a normal value would be 40, we look at whether or not an elevated PCO2 would cause for or account for an elevated hydrogen ion and a lower pH. And indeed, yes, when the PCO2 is up, the hydrogen ion is up and the pH is down, okay? So indeed, this excess CO2 is going to cause the problem here. And so we're going to say that this appears to be a respiratory acidosis, okay? Then we look at the bicarb. So to make sure that we don't have a mixed issue going on here causing the acidosis, and is there evidence that the body might be compensating? So to determine that, we look to see if the bicarb parameter is high or low. Since the value from our example is 30 and the normal level is 24, we're going to say the value is higher than normal. And when there is a high bicarb, it doesn't tend to make things acidic, tends to make things alkalotic. So we're going to say this high bicarb is attempting to change this acid concentration through its buffering process. So we will call this a primary respiratory acidosis, and the renal system is compensating. All right? Okay, and actually what that would be called completely in the terminology is respiratory acidosis with partial compensation by partial renal compensation. Not completely compensated because remember, the pH was not back to normal. So our take-home lessons: regulation of acid base is by respiratory and renal systems. Respiratory regulates by altering the rate and depth of ventilation to either retain or get rid of the carbon dioxide, which we consider to be essentially acid because it matches or it causes the increased level of hydrogen ion. Okay? Renal system retains or eliminates the bicarbonate, and so that is a factor in kind of neutralizing those excess hydrogen ions. Okay. Disturbances are either primarily respiratory or metabolic. Your metabolic disturbances can be renal or digestive. Multiple things can cause it. But the compensation, when there is compensation going on, it's either respiratory or renal. Okay. And as I was telling you earlier with the arrows, there's an acid-base memory aid, a mnemonic. It's called ROME. Means respiratory opposite, metabolic equal. So when we see, as in this picture here, the pH is up and the PCO2 is down, the arrow's going in the opposite directions, it's a respiratory problem. And when the pH is going down and the PCO2 up, again the opposite directions, that means it's a respiratory problem. Metabolic, on the other hand, is equal. So the arrows are going in the same direction. pH up, bicarb up, it's a metabolic condition. pH down, bicarb down, it's a metabolic condition. Okay? So for these case examples, I think we will end up doing these in class also, but I'll just talk you through here. We're going to just take these case examples using the parameters that we set up earlier. We're going to look to see if the person is in a respiratory or a metabolic acidosis or alkalosis, and then we'll try and see if there's compensation going on. Remembering that we're going to use these ranges, 7-4 as the norm for our pH, 40 for the PCO2, and 24 for the bicarb, even though that is kind of a middle instead of the normal range. Okay, we'll start using the normal ranges a little bit later. Okay, so for patient number 1, reading across on the top of the chart there, the one we just discussed, pH is 7.25, so I would put a down arrow in that box between patient and pH, and the PCO2 70 is elevated. I put an up arrow in the box between pH and PCO2. And then the bicarb seems to be going up, and so I would put an up arrow there. When I look at the arrows, I see they're going in opposite directions for pH and PCO2, so now that keys me in that this is a respiratory event. And the bicarbonate is actually moving or increasing in a method that would counteract the pH, so there's compensation going on there. So the patient 1 has a respiratory acidosis with partial renal compensation. Patient number 2, pH 747, it's elevated, so the arrow would go in the box between patient and pH is up, and the PCO2 is 20, lower than normal, so the arrow between pH and PCO2 would go down, and then the bicarb is also going down. It's lower than what we would expect. And that I would put a down arrow then in the box between PCO2 and the HCO3. So again, just looking at my arrows, we've got the pH up, the carbon dioxide down, moving in the opposite direction. So this is a respiratory issue. The pH is elevated, so it's alkalotic, so this is a respiratory alkalosis. The bicarb level is decreasing, and so less bicarb means less alkalosis, and so the bicarb is moving in a manner that's going to counteract the pH. So patient 2 is respiratory alkalosis with partial renal compensation. Patient number 3, pH, that is down. So the arrow between patient, the box between patient and pH would have a down arrow. PCO2 is going down also, so the box between pH and PCO2 would go down, the arrow would go down, and HCO3 is also going down, so the box between the PCO2 and the HCO3 would have an arrow pointing down. Now I notice that my pH and my bicarb arrows are going in the same direction, so this has to be a metabolic issue. Okay, so it's a metabolic acidosis because the pH is low in the acidic area. The PCO2 is decreasing, and so a decreased PCO2 does not cause acidic issues. It's going to actually counteract the acidic issue, and so this PCO2, the respiratory system is compensating. So patient 3 has a metabolic acidosis with partial respiratory compensation. Patient number 4, the pH is 7.5, it's elevated, so the arrow in the box between patient and pH would be pointing upward. PCO2 is 49, and that is elevated, and so the arrow in the box between pH and PCO2 would be pointing upward, and the HCO3 is elevated also. So the bicarbonate, the box between the PCO2 and the HCO3 would have an arrow pointing up. Again, the pH arrow and the bicarbonate arrow are going in the same direction, so this is a metabolic disorder. It is an alkalytic situation with the pH, so this is a metabolic alkalosis, and the PCO2 is elevating, which does not cause an alkalotic situation, but instead would be more likely to be seen in the opposite, in an acidic condition. So the lungs are working in this case to counteract this situation. So patient 4 is a metabolic alkalosis with partial respiratory compensation. Okay? And this is just step by step what you would do to determine that. Here's another case study. Gal with cystic fibrosis. Right away you can probably think cystic fibrosis, the person's going to have problems breathing, and so likely is retaining CO2. She's very likely with this particular diagnosis to have a respiratory acidosis going on, but let's just look at her blood gases and we see the pH is low, 7.3. The PCO2 is high, 50. So right away we've got the arrow of the pH pointing down, the arrow of the PCO2 pointing upward, moving in opposite direction, so it is indeed a respiratory acidosis. The bicarb, however, is normal, so there's no compensation going on in this particular case. Okay? And those are the questions. I just answered them all. Here's the next case, woman with vomiting. I'm going to think vomiting, yeah, she might be getting rid of that hydrochloric acid, but be that as it may, we look at her blood gases, and she's got a pH 7.5 elevated, so she's alkalotic. PCO2 is normal, so it can't be a respiratory alkalosis, but look at the bicarb, elevated. And also the bicarb arrow is pointing up because it's increasing. The pH arrow is pointing up, so it's increasing. So the pH and the bicarb are moving in the same direction, so this is a metabolic alkalosis, and there is no compensation. The PCO2 is in the normal range. Okay, and that is actually the questions we just answered. Moving to the next case, we've got a pH 7.31 with which would be low, so the arrow would point down. PCO2 is actually also low, so we know it's not a respiratory condition because that arrow would point down. Bicarb is low, so we know with the arrow pointing down, the bicarb and the pH, it's a metabolic condition. This appears to be metabolic acidosis, and there is some compensation by the respiratory system because the PCO2 is moving in a way that would counteract the situation. Again, those are the questions. We just answered them. And that is all for this particular set of lectures. Thank you.